I am Mahamoudou Toure from the West African ICEMR, and I will be presenting our implementation research for improving seasonal malaria chemoprevention strategy in Mali. So as you all know, SMC has been recommended, SMC with sulfadoxine pyrimethamine for children less than 5 was recommended by WHO in 2012. And since 2016, it's implemented countrywide in Mali. But before, in 2015, Mali has implemented SMC in 50 pilot study. But at the beginning, none of our ICEMR sites were concerned. But because of our collaboration with the National Malaria Control Program, they allow us to use to implement SMC in one of our sites, which is Dangasa, because we were following a cohort of a dynamic cohort since 2012 in this site, and this gives us the opportunity to provide strong evidence on the efficacy of SMC in preventing disease during the high transmission season. So also, as Dumbia was presented, we also, from our historical data on malaria incidence and prevalence, we also observed since 2012 that malaria was highly seasonal in Dangasa, but transmission was very long, 5 to 6 months a year, from July to December. So here I'm going to present two studies. The first one will be the extension of SMC to children 5 to 14 years old. And the rationale is that we have observed a shift of the malaria burden among the children 5 years and plus. Then we decided to see what will be the effect of implementing SMC with SP-AQ among those children in the high transmission area of Dangasa. Then the second one, as you can observe, we have been implementing SMC 6 years from now, from 2015, but still we are observing some malaria cases among children who are receiving SMC. So this call for the multiple challenge we are facing for SMC, which can be the compliance to the full treatment, the drug side effects, and also the coverage. So then secondly, I will present you a pilot study where we use dihydroartemisinin piperacin versus SP-AQ for SMC in Kulikoro, one of our study sites. So the first study, as I said, SMC implementation has been highly effective in reducing malaria in children less than 5, but we observe, and it has been observed also in many places in Africa, that malaria burden is increasing among children age 5 to 14, school years children, which in the case of Mali are not targeted by SMC and not only benefiting by, from the free malaria diagnostic and treatment at public health structure. So the question was how SMC provision to the children 5 to 14 years will impact malaria burden in endemic area. So the study aimed to assess the efficacy of SMC and also its acceptability for children as old as 14 years old in Dangasa over 3 rounds instead of 4 as usual. So the study design, so we randomized study population into 2 groups, 175 each, and the intervention group, children within the intervention group, the 5 to 14 years receive SMC, while the children in the control group did not receive SMC. So we perform a baseline survey to characterize malaria infection, asymptomatic infection prevalence, and also at the end of the 1 month after the last round of SMC, And during the study period, passive case detection was performed at the community health center to characterize malaria incidence in the two study arms. So as you can see, in terms of acceptability, parents and community are really willing to have SMC for this age group because they see the benefits to this study. And also in terms of prevalence of P. falciparum, you can see the declines observed in the intervention group, and also the decline observed in the prevalence of anemia in the observation group, the intervention group versus the control group. So at the end, the malaria first episode was assessed in the two study arms. So you can see that the cumulative incidence of P. falciparum malaria was 14.7% in the intervention group versus 75.4% in the control group. So by providing SMC to children of 5 to 14 years, we were able to avert 34.7% of new plus P. falciparum malaria cases in the intervention group. So secondly, as I said, that this is a pilot study using a clinical randomized trial to assess the effectiveness of SMC using different treatment regimen in Kulikoro. So overall, we want to evaluate the efficacy of SMC with respect to implementation, morbidity, cause, and protective immunity to malaria, and potential emergence of drug resistance. So this study pilot was carried out to inform a large district-wide randomized study for using three different treatment regimens. So the first study arm received the standard SMC SpAQ for the less than 5, and the first intervention group, so SMC with SpAQ was extended to the less than 10, and the third group received only DHAPQ for SMC up to 10 years old. So then we want to determine the potential impact of the strategy on malaria epidemiology, protective immune, parasite population, and drug resistance. So then to perform a district-wide cluster randomized study to determine the effectiveness of extending SMC to older children, and also the use of DHAPQ for SMC among the children less than 10 years old. We also, economic-wise, we also will perform a cost effectiveness analysis to see to compare the two drugs where they are used for SMC among children less than 10 years old. So here I'm presenting the pilot study that was in 2019 and 2020 in 9 villages of Kulikoro. So the randomization scheme is on the right of the screen. So you can see that in each study arm, we have 3 villages, 1 village along the river and 1 village in the middle of the region and 1 village in the dry area of the region. This was in respect with the ecological characteristic of the study site. So both ecological patterns was represented in each arm. So the first year, arm 1 received the standard SMC, and then the second year we extend the SMC with SpAQ up to 10 years old, and you can see the rest on the figure. So there was a shift on intervention between arms in the second year. So some results. So the first one is the incidence, cumulative incidence of malaria by study arm among the children less than 5 years old. So here in green, we have the incidence in the standard arm, the control, where we continue to give SMC to only the less than 5. Then the green one is SMC with DHAPQ, and the pink one is SMC with SpAQ, but in place where it was extended to the less than 10. So here we can see that even by extending the SMC to the 5 to 9, the children less than 5 may benefit. So there is a community benefit of the extensions in terms of reduction of the incidence. So the second graph is only about the 5 to 9 years old. And here in arm 1, the 5 to 9 years old did not receive SMC at all. So SPAQ was given in the second arm and DHAPQ was given in the third arm. So here you can see specific at all moment after the first round of SMC, you can see that the incidence is 3 to 5 times in the control arm compared to the 2 intervention arm, SPAQ and DHAPQ. So from this pilot study, so we have now designed a district-wide cluster randomized controlled trial. So using only 2 study arms. The first arm, children up to 9 years old receive SPAQ, while in the second arm, we are giving DHAPQ. So we will also determine the potential impact of the strategy on parasite population, genetic drug resistance markers, breakthrough infection among children, and also we will identify molecular marker associated with drug resistance. So during the study also, we reinforced the malaria surveillance data reporting system at district level by implementing electronic data capture at the community health center, and reporting can be fast and more accurate in rural setting. So this, for the big trial, we completed the first year, 2021, and we are now preparing for the second year. So we, out of the 71 health catchment in Kulikoro, we randomly select 49, and these 49 have been randomized into 2 groups using a PPS sampling. So at a ratio of 2 DHAPQ for 1 SPAQ. So, so the stratification factors were the type of health catchment, the site population size, and the prevalence of asymptomatic P infection at baseline as well as LL line coverage. So last year we were from the census we get about 17,000 children in the DHAPQ arm and 8,500 children in the SPAQ arm. Enrollment was about 97 to 99% of children identified and given a unique ID for the study. And the main reason for non-enrollment were children who travel up between the census and the first round of SMC. And also we get some refusal to participate into the study. So to summarize, I will say that SMC with SPAQ is effective in reducing malaria burden among children older than 5 years old. And SMC provided provision over 5 months versus 4 months can contribute in reducing the rebound in malaria case observed at the end of the season in area with longer transmission season like Dangasa. Also, from the pilot study, we can say that DHAPQ is at least as effective and perhaps more than SPAQ in preventing malaria, while minimizing the side effect in children less than 10 years old with significant community level benefits. So these benefits are, for instance, the test of the drug, which make it more acceptable to children, and this increase the compliance to the treatment, and less side effects compared to SPAQ. Also, we observed that over the SMC campaign, the coverage rate for DHAPQ increased progressively, while the coverage rate for SPAQ decreased over time. So yeah, so this year we will be running the second year of the district-wide clinical trial, and then data can be published after that. Thank you very much for your time, and thank you for having me on this session.